Welcome to the Deep Dive, your shortcut to being truly well-informed, tailored specifically for you. Today, we're plunging into what feels like a really pivotal moment in global health governance. We've received sources that reveal a major announcement regarding America's stance on the World Health Organization's pandemic response measures, specifically, the Trump administration's formal rejection of key proposals. Okay, let's unpack this. It's a crucial development.
It really is. This is more than just a policy decision. It feels like a critical juncture for how nations will collectively, or maybe individually, face the next global health crisis. We're talking about the formal rejection by the U.S. of specific reforms to the international health regulations. And this is alongside ongoing developments concerning a broader, quite separate pandemic agreement. What's truly fascinating here, I think, is how these, divergent decisions are going to shape the future landscape of pandemic preparedness and response.
Precisely. And our mission today is to thoroughly explore these WHO-led pandemic response efforts. We need to understand which countries are on board, which are not, weigh the potential pros and cons of these, frankly, strikingly different approaches, and ultimately consider how all of this will impact our collective ability, to control future pandemics. You might be wondering, what exactly are these international health regulations? And why were new agreements even necessary after the devastating lessons of COVID-19? To really grasp the gravity of this U.S. decision, I think we need to start by laying some foundational groundwork.
Yeah, absolutely. Makes sense.
So to truly understand the headlines we're seeing today, we need to rewind the clock a bit, uncover the surprisingly long history of nations trying to, outsmart global health threats. The World Health Organization didn't just appear on the scene during COVID, did it?
Not at all. The International Health Regulations, or IHR, they aren't new. They're really a cornerstone of global health law. It's a legally binding instrument that has evolved over, more than a century and a half. Their roots actually stretch back to the mid-19th century. Think about countries grappling with devastating outbreaks like cholera, plague, yellow fever, spreading rapidly across borders.
Right. Before modern travel even.
Exactly. And the challenge then, much like now, was how do you contain disease without simultaneously grinding global trade and commerce to a halt? Imagine the complexities, early quarantines versus bustling port cities. This tension, it's always been there. Public health versus economic flow, it's at the heart of these regulations.
This deep history is really striking. So when did they become the modern IHR we've heard so much about?
Well, the IHR, as we largely know them today, were last significantly revised in 2005. This was a direct, pretty urgent response to the 2002-2004 SARS outbreak.
SARS.
Yeah. Which really revealed how quickly a novel pathogen could just traverse the globe. These 2005 regulations, they came into force in June 2007. And by June 2020, just before COVID really exploded globally, they were legally binding on 196 countries. That includes virtually all WHO member states.
Wow, almost universal then.
Pretty much. And it's important to understand the IHR is the only international legal treaty that truly empowers the World Health Organization to act as the central global surveillance system for public health threats. It's kind of their eyes and ears for what's brewing worldwide.
And that revision in 2005, it sounds like it marked a major shift. What did it fundamentally change about how the world approached outbreaks?
It was a huge shift, actually. The older, a 1969 IHR, primarily focused on a narrow list of specific notifiable diseases, think cholera, plague, yellow fever again. But the 2005 revision broadened that scope dramatically. It moved from just a limited list to recognizing that any public health incident, not just a specific disease, could pose a significant global threat if it crossed borders.
Okay, so much broader.
Much broader. And these broader threats, if they were serious enough, were designated as a public health emergency of international concern. This framework finally acknowledged the, interconnectedness of our modern world and the need for a far more comprehensive approach to global health security.
The PEEIC. PEEIC, right? That term became incredibly familiar during the pandemic. So, if it's the WHO's highest alarm bell, what exactly defines a public health emergency of international concern?
Yeah, think of a PEIC as the WHO's most urgent global alert. It's defined pretty specifically as an extraordinary event which is determined to constitute a public health risk to other states through the international spread of disease and to potentially require a coordinated international response.
Okay, so extraordinary event is key.
Right. It means it's not just serious, it's typically sudden, unusual, or unexpected, and crucially, it must carry implications for public health beyond the affected state's borders. And it may require immediate international action. It's meant to be an urgent call to arms, basically, mobilizing global resources and attention.
And countries have to respond.
Well, under the 2005 IHR, states have a legal duty to respond promptly to such a declaration. It carries weight.
So how does this alarm actually get sounded in practice? Who declares a PHEIC, and what's the process involved?
The declaration itself falls squarely to the WHO Director General.
Okay.
But it's not a unilateral decision. It's made after careful consideration of advice from an IHR Emergency Committee, or EC. This EC isn't a permanent body. It's a specially assembled committee. International experts created ad hoc for each specific event.
Ah, so tailored to the crisis.
Exactly. These experts review all the available data, use legal criteria, a predetermined algorithm. They assess the crisis thoroughly. And since 2007, this alarm system has been activated numerous times for major crises. You had the 2009 H1N1 swine flu,
I remember that one.
the 2013-2016 West African Ebola epidemic, the 2016 Zika virus outbreak,
Zika, right?
and most famously, of course, the 2019-23 COVID-19 pandemic, but also others like polio declarations, Mpox outbreaks. It's a mechanism designed for, well, varied application.
It sounds like a remarkably robust framework on paper. But even with those 2005 revisions, were there significant criticisms, moments where the IHR didn't quite hold up, even before the catastrophic impact of COVID-19?
Yes, absolutely. Despite the 2005 revisions aiming for better global health security, the real-world application definitely exposed some persistent gaps. The WHO's response to the West African Ebola epidemic from 2013 to 2016, it was perceived by many as delayed and inadequate, and that brought intense scrutiny back onto the IHR.
Right, I recall that criticism.
High-level panels assessing that response highlighted this persistent need for more integrated thinking. It wasn't just about strengthening national health systems in isolation, but ensuring true health security. And here's a sobering statistic. By 2015, a significant number of countries, 127 out of 196, still couldn't meet the 8 core public health capacities outlined in the IHR.
Wow, that's a lot, over half.
Yeah. And the core insight from these earlier IHR challenges is that, well, legal frameworks alone just aren't enough. You can have the most robust regulations on paper, but if countries lack the capacity to actually implement them.
Or if they're scared to report.
Exactly. If reporting is disincentivized by fears of, say, unjustified trade and travel restrictions being slapped on them, the entire system can break down. It creates this classic gap between intention and execution, and that really set the stage for the next, even larger crisis.
So with that historical context in mind, it almost feels, well, inevitable that a crisis like COVID-19 would expose those cracks in the global health architecture, doesn't it? It certainly felt like it revealed some profound systemic gaps.
It absolutely did. The COVID-19 pandemic didn't just stress the need for a globally coordinated response, it screamed for it. It exposed what the WHO Director General, Tedros Adhanom Ghebreyesus, starkly called a catastrophic failure.
Strong words.
Very. And despite the WHO's significant efforts, they notified member states on January 5th, 2020, confirmed human-to-human transmission by January 20th, declared that PAEIC on January 30th, called it a pandemic March 11th.
Right, those dates are seared into memory.
But the sheer unprecedented scale of the crisis just highlighted profound shortcomings in the existing international health architecture. The mechanisms simply weren't sufficient to manage a crisis of that magnitude, and that led to, tragic losses of life and devastating economic consequences.
So the pandemic pushed for even more comprehensive reforms, essentially a complete rethink. What were the core motivations driving these new initiatives, both the IHR amendments and that proposed separate pandemic agreement?
Well, the overarching vision was really to foster an all-of-government and all-of-society approach to future health threats. The goals were pretty clear: dramatically strengthen national, regional, and global capacities and resilience for future pandemics. This meant ensuring the world would be far better prepared, preventing a recurrence of such a catastrophic failure, and, crucially, addressing those critical issues at global equity and solidarity that became so painfully apparent during the COVID-19 response.
Equity and solidarity.
Yeah. The ambition was to move beyond just reacting to outbreaks and towards proactive prevention and preparedness, really learning from what went so wrong.
And how did they plan to achieve that? What concrete changes were actually on the table?
Okay, so for the IHR amendment specifically, the proposed changes aim to expand the regulations, improve the international response framework. This included adopting a clearer, more precise definition of a pandemic emergency and how it could be triggered. The idea was more consistent global application.
More clarity, less ambiguity.
Exactly. There were also significant efforts to improve information sharing between countries and the WHO, recognizing that early, transparent, rapid data is just the lifeblood of an effective response. And then a major, and as it turned out, highly contentious point, allowing poorer nations equitable access to medical products. Ah, the access issue.
Right, to equitably address the needs and priorities of developing countries. This was a direct attempt to fix those glaring disparities we saw during COVID-19.
Equitable access to medical products, especially vaccines. That was a truly monumental issue during COVID. That sounds like a direct response to the vaccine nationalism that Dr. Tedros warned against, where richer countries essentially hoarded supplies.
It was precisely that, the COVAX program during COVID-19, which aimed for equitable vaccine access. Well, it significantly underscored the immense challenges of ensuring fair distribution. So the goal of these new IHR measures was to make these principles of equity and access more binding, more operational within the existing legal framework.
Got it. Fixing the existing system. Right. But beyond these amendments to the existing regulations, there was also that separate, even broader initiative, a brand new pandemic agreement. Negotiations for this comprehensive international convention, they launched in December 2021. And global health experts had held really high hopes that this transformative treaty would be finalized by the 2024 World Health Assembly, signaling, a new era of truly global cooperation.
So what's striking here is that there wasn't just one new thing happening, but two distinct parallel initiatives. One was trying to fix the existing house, the IHR, and the other was trying to build a completely new one, the treaty.
Exactly. This dual-track approach was quite strategic. It aimed to tackle both immediate operational improvements through the IHR amendments, making the existing system work better, and a more fundamental long-term restructuring of global health governance through a new legally binding international treaty. The hope was that together, these efforts would create a far more resilient, equitable, and effective system for the future. The ambition was, as the report title said, to truly make it the last pandemic.
Ambitious goal. Okay, this brings us to the core of today's deep dive, and the headline news that's really shaking up global health circles. We've set the stage with the IHR and the urgent impetus for reform. Now, let's pivot sharply to the recent critical announcement regarding the United States.
Indeed. So on Friday, July 18th, 2025, the United States formally rejected changes to the World Health Organization's pandemic response rules. And this wasn't just a subtle shift. It was a definitive, very public rejection.
Formal rejection.
Yes. And this significant decision came months after President Donald Trump began the process of withdrawing the U.S. from the UN health body, the WHO, upon returning to office in January. But even with that broader withdrawal process in motion, the State Department indicated that the language in these reforms, the ones adopted by the World Health Assembly just last year, 2024, would have still remained binding on the United States.
Okay. So even withdrawing didn't automatically negate these specific changes.
Apparently not, from their perspective. This perceived lingering obligation, despite the withdrawal process, made a formal rejection necessary in their view.
Okay, let's really unpack this. This wasn't just a quiet disagreement. It was a formal public rejection. What were the explicitly stated reasons for this significant move by the Trump administration?
Well, in a joint statement, Secretary of State Marco Rubio and Health and Human Services Secretary Robert F. Kennedy Jr. were exceptionally clear and direct. They stated that the amendments, and I quote, risk unwarranted interference with our national sovereign right to make health policy.
Unwarranted interference. Strong phrasing.
Very. They went further, stating emphatically, we will put Americans first in all our actions, and we will not tolerate international policies that infringe on American speech, privacy, or personal liberties. So this highlights an unequivocal emphasis on national control, national sovereignty, and individual rights as the absolute cornerstone of their decision. It prioritizes domestic autonomy above international coordination.
So the central concern here was sovereignty and individual liberties. Did they elaborate on what specific provisions or what kind of language in these amendments specifically raised these red flags for them?
They did give some specifics. The U.S. was specifically disassociating itself from that series of amendments to the IHR adopted last year in Geneva. Rubio and Kennedy asserted that, again quoting, Terminology throughout the amendments to the 2024 International Health Regulations is vague and broad, risking WHO coordinated international responses that focus on political issues like solidarity rather than rapid and effective actions.
Wow, calling solidarity a political issue rather than a public health principle.
It's a significant framing, yes. They pointed directly to the inherent language as problematic, suggesting it lacked the precision needed to avoid overreach. Furthermore, they sharply criticized the WHO's perceived political vulnerability. They stated, the changes fail to adequately address the WHO's susceptibility to the political influence and censorship, most notably from China during outbreaks.
The China criticism again.
Right. They essentially argued that the WHO's initial response to COVID-19 revealed critical weaknesses that these new amendments failed to rectify. And lastly, Kennedy and Rubio claimed that the amendments compel countries to adopt digital health documents. Compel.
That was their claim, though other sources clarify that the reforms actually require the WHO to develop a database for digital health certificates
Okay.
that participating nations would voluntarily submit information to, not a mandatory imposition. So there's a clear discrepancy there between the stated concern and what the text apparently says.
That distinction between compelling adoption versus developing a voluntary database seems pretty crucial, and calling solidarity a political issue is a particularly striking point, especially when the WHO, as we discussed, explicitly mentions solidarity and equity as a core commitment in these very reforms. It feels like a direct clash of ideologies.
It absolutely is
Yeah.
a profound ideological clash. And this move indeed aligns perfectly with a specific political stance that has gained traction, particularly within conservative circles in the U.S. and other countries. There has been stiff resistance to broader attempts to agree on a pandemic treaty for some time, rooted in a suspicion of multilateral institutions and this view that international rules infringe on national sovereignty.
We saw that during COVID itself. Exactly. Measures like lockdowns, vaccine mandates, they became deeply contentious political issues in the U.S. Many right-wing activists vehemently rejected such interventions. Senator Ron Johnson of Wisconsin, for example, a vocal critic of the WHO, publicly applauded the administration's decision. He argued the COVID-19 pandemic exposed the WHO's incompetency and corruption. And he further claimed the WHO sought to declare public health emergencies in member states, which could include failed draconian responses like business and school closures and vaccine mandates.
So the narrative is potential coercion overreach.
Right. This perspective frames international health efforts as potentially coercive and harmful to national and individual freedoms, rather than a necessary collective defense.
That's a remarkably powerful argument about national control versus global coordination, especially when you juxtapose it with the devastating human and economic costs of COVID-19. The WHO estimates, 7 million people killed? More than $10 trillion wiped from the global economy?
The numbers are staggering. The debate is absolutely about how to prevent such devastation again, but the chosen methods are clearly polarizing the world.
The how is the sticking point.
Absolutely. The human and economic costs were immense, creating an undeniable impetus for fundamental change. But the core question of how to implement that change and who ultimately holds the authority in a crisis, that remains a deep point of contention. This formal rejection by the U.S. really underscores that even after a shared global trauma like COVID, the pathways to prevention and response are far from universally agreed upon. It highlights that enduring tension, global solutions versus national autonomy.
Okay, this is where it gets really interesting, because it's incredibly easy to confuse these two things, but they're absolutely distinct, as you said. We've been talking about the IHR amendments that the U.S. formally rejected, but there's also that separate, even more ambitious initiative, the broader pandemic agreement or treaty.
You are absolutely right to draw that critical distinction. It's easy to conflate them. The WHO Pandemic Agreement, often called W.H.O, is a completely separate international agreement. Its genesis lies in the recommendations from that independent panel for pandemic preparedness and response.
The one Dr. Tedros set up.
Exactly. Set up in July 2020, specifically to examine why COVID-19 became such a global catastrophe. Their May 2021 report, titled COVID-19, Make It the Last Pandemic, issued a strong call for this new pandemic treaty as a fundamental way to build a more resilient global health architecture. It was designed to fill the gaps the IHR simply couldn't.
So the treaty is a completely new legal instrument, a fresh start, whereas the amendments were changes to existing rules. How did the world respond to this new comprehensive treaty? Was it embraced universally?
Well, on May 20th, 2025, at the World Health Assembly, 124 members of the WHO officially adopted the WHO.
124, that's a significant number.
It is. It represents a strong global commitment. However, it was definitely not a unanimous decision. There were 11 countries that notably abstained from the vote, including names like Poland, Israel, Italy, Russia, Slovakia, Iran.
Okay, some significant abstentions there.
Yes, and as you might anticipate, given their earlier stance, the United States, already deep in the process of withdrawing from the World Health Assembly, declined to participate in the vote for the pandemic agreement at all.
So they didn't even abstain, they just didn't participate.
Correct. And Robert F. Kennedy Jr. also publicly criticized these proceedings in a televised address, underscoring the U.S. administration's consistent and strong opposition to these global initiatives. Even when they weren't directly casting a vote, it clearly indicated a fractured global consensus.
That's a powerful statement from the U.S. side, even in their non-participation. What does this new pandemic agreement actually say, especially regarding those sovereignty concerns we heard earlier from the U.S.? Because Tedros himself had called claims of sovereignty snatching fake news during the negotiations.
Right, and that's a crucial point to clarify because the drafters of the agreement were very much aware of these concerns. They tried to address them head on. The agreement explicitly rules out the WHO holding any authority to direct, order, alter, or otherwise prescribe any policy, or to impose any requirements that parties take specific actions.
Okay, that sounds pretty definitive.
It was meant to be. That language was specifically and deliberately included to directly address fears of overreach and to safeguard national sovereignty. It does, however, refer to the WHO as the directing and coordinating authority in the event of a pandemic.
But that's different from directing policy.
Exactly. It's entirely consistent with the WHO's existing constitution, simply reaffirming its established, non-coercive role in global health coordination.
It seems to directly tackle those sovereignty-snatching claims head-on. Tedros even stated earlier something like, negotiating members know that the agreement will give WHO no such powers because you are writing it. That's about as clear as it gets.
It is, and that was the express intention behind the meticulously crafted language. Yet, despite this explicit clarification within the agreement and direct refutations from the WHO Director General, the perception of potential overreach and the pushback persisted significantly.
Really? Even with that language?
Yes, a particularly notable example occurred back on August 29, 2024, when Republican governors of 26 U.S. states issued a joint statement declaring they would not comply with the treaty.
Before it was even adopted.
Before it was formally adopted. This demonstrates that even with explicit safeguards and public reassurances, strong domestic political opposition based on deeply held sovereignty concerns continued to be a powerful and unwavering force. It shaped national responses regardless of the international legal text.
Fascinating. So even with those explicit safeguards, the pushback persisted. If not the direct assertion of WHO authority, what then were the most contentious sticking points during the actual negotiations for this treaty? What was the true flashpoint?
Okay, beyond the general sovereignty concerns, the most crucial and genuinely contentious stipulation was undoubtedly the issue of intellectual property rights, IPRs.
Patents and things.
Exactly. This became the real flashpoint. Organizations like the South Center, which represents the interests of many developing countries, argued quite strongly that the WHO pandemic instrument should commit parties to limit the exclusionary effects of government-granted patents and other IPRs during pandemics.
Why? What was their reasoning?
Their rationale was compelling. Doing so would support the rapid diffusion of new vaccines, diagnostics, medicines. Critically, it would facilitate collaboration and freedom to operate for manufacturers worldwide.
Get production going faster everywhere.
Precisely. They even proposed an obligation for parties to temporarily suspend IPR enforcement that creates barriers to manufacturing and supply. They pointed to existing TRIPS flexibilities under the WTO agreement mechanisms many countries already have the right to use, but often face pressure not to.
So use existing tools more effectively.
Right. Their perspective was that the current draft text of Article 11, which covers technology transfer, wouldn't make any significant change to the status quo, and they viewed that status quo as wholly insufficient for an equitable and rapid pandemic response. They saw existing IPRs as a bottleneck.
And the pharmaceutical industry's position on this, because they were a major player, obviously, making substantial profits during the COVID-19 vaccine rollout, they definitely have a vested interest.
Oh, absolutely. The transnational pharmaceutical industry was adamantly opposed to any reference to IPRs in the treaty that would limit their rights or mandate waivers. They argued that such limitations could undermine the protection of IPRs, which they assert is essential for them to recoup massive research and development investments and, yes, reap profits from vaccine and medicine sales.
The innovation incentive argument.
That's their core argument. Robust IPRs are the critical incentive that drives innovation and the development of new life-saving tools. Without those protections, they claim, the next breakthrough might not happen. And countries like Germany and most European nations also largely opposed major limitations on IPRs, stating quite bluntly that an agreement with such limitations will not fly.
So a real north-south divide on this, it sounds like.
Very much so. It really showcases this profound tension between the immediate public health imperatives of a global crisis and the commercial interests and economic models that underpin pharmaceutical innovation.
So the core belief on one side is that strong IPRs incentivize innovation, leading to future breakthroughs. But the counterargument is that in a pandemic, public health must come first, potentially even above profit, to ensure equitable access. This raises an important question. How do these opposing views, national sovereignty versus global cooperation and IPR protection versus public health access, how do they play out in the context of future pandemics? When the next global health crisis inevitably hits, it feels like we're caught between two essential but often conflicting priorities.
That's exactly the tension.
We've explored the U.S. formal rejection of IHR amendments and its non-participation in the pandemic agreement, rooted in these deeply held concerns over national sovereignty and individual liberties. Now, let's try to connect this to the bigger picture. What are the compelling arguments for strong international cooperation in a global health crisis? And what are the equally powerful counterarguments for prioritizing national sovereignty?
Okay, connecting to the bigger picture. Advocates for robust international cooperation present a compelling and I'd say increasingly urgent case. Pandemics, by their very nature, simply do not stop at borders. That's the fundamental reality. In our deeply interconnected world, where people and goods traverse the globe in hours, a disease outbreak in one country can rapidly, almost instantaneously, become a global crisis. We saw that unequivocally with COVID-19.
That's undeniable.
Therefore, from this perspective, a coordinated international response isn't merely beneficial, it's absolutely essential. For effective prevention, early detection, rapid containment, it's about collective security in a world where pathogens travel at the speed of human movement. A weak link anywhere truly does affect everyone, everywhere. You can't wall yourself off.
So the idea is that we are genuinely all in this together, and a failure to act cohesively somewhere will inevitably impact everyone everywhere else, like ripples in a pond.
Exactly. And proponents of cooperation emphasize the critical need for truly equitable access to medical countermeasures, vaccines, diagnostics, medicines for all countries, not just the wealthy ones. They point directly to the painful, undeniable lessons of COVID-19, where early, transparent information sharing was crucial, and where a severe lack of equitable access to vaccines and treatments led to prolonged suffering, unnecessary deaths, massive economic disruption, particularly in lower-income nations.
The images were stark.
They were. The concept of solidarity and equity is seen as absolutely fundamental from this viewpoint, ensuring that low-income countries are not abandoned due to resource limitations or intellectual property barriers. And this is precisely where calls for temporarily lifting IPRs during emergencies come from, often citing those existing TRIPS flexibilities under the W.H.O agreement.
Which you mentioned countries already have a right to use.
Many do, yes, but they need to be more universally applied and facilitated during crises. The argument is clear. The immediate public health good, the saving of lives, must outweigh commercial interests during an emergency of global proportions.
That makes profound sense from a public health standpoint. But on the other side, the arguments for prioritizing national sovereignty and against these specific international measures are equally strong for those who hold them. We heard some of them quite clearly from the U.S. administration.
Yes, and these concerns are significant and deeply held by those who champion them. They center on this core idea that international policies, particularly those perceived as legally binding or coercive, might infringe upon a nation's sovereign right to make its own health policies. This could, in their view, lead to unwarranted interference in domestic affairs.
Right.
This includes profound fears that international bodies could somehow order global lockdowns, impose draconian responses like mandatory business and school closures, or mandate vaccines for their citizens.
Even though the text tried to prevent that.
Exactly. While, as we discussed, the pandemic agreement explicitly states the WHO cannot direct, order, alter, or otherwise prescribe specific actions, the perception of potential overreach,
Perception is key.
or the interpretation of general language as enabling such overreach, remains a powerful counterargument for those who prioritize national autonomy. They see potential for mission creep, for unintended consequences down the line.
And we heard those criticisms about vague and broad terminology allowing for political interpretations and concerns about censorship, especially linked to China.
Correct. There's also that very strong concern about the WHO's susceptibility to political influence, particularly from powerful nations. Critics argue that this influence, most notably from China, led to censorship or delayed information during the critical early stages of the COVID-19 outbreak. From this perspective, an over-reliance on international instruments, especially those with perceived flaws, political vulnerabilities, or a track record of being influenced by certain states, well, it could jeopardize national security and citizens' liberties, including speech and privacy rights.
So trust in the institution itself is a factor.
A huge factor. And the pharmaceutical industry's opposition to IPR waivers also falls into this category. They argue protecting intellectual property isn't just about immediate profit. It's crucial for incentivizing the immense, risky R&D needed to create new life-saving tools. Undermining IPRs, they contend, would stifle future innovation and leave us less prepared for the next big threat.
So it's a complex balancing act. Global interconnectedness versus fiercely defended national self-determination.
That's the fundamental tension, yes. Does a nation surrender a degree of autonomy for collective gain, or hold firm to its internal decision-making, even if it might risk broader global impact? There's no easy answer.
This brings us to the ultimate question, the real so what of this deep dive. With the U.S. rejecting IHR amendments and not participating in the pandemic agreement, and with other significant countries abstaining or holding firm on issues like IPRs, what does this fragmented landscape actually mean for controlling the next pandemic?
Yeah, this raises that critical question. Will these fragmented approaches truly help control future pandemics? Or will they simply perpetuate the very challenges we faced, awfully disastrously, with COVID-19? Look, the core objectives of these international measures are undeniably crucial. They're widely accepted as necessary. We're talking about ensuring early detection of novel pathogens,
Crucial.
rapid, transparent information sharing across borders, equitable access to medical products like vaccines and treatments for everyone, globally coordinated responses that aren't hampered by nationalistic impulses. COVID-19 starkly demonstrated these elements aren't just ideals, they are absolutely vital for mitigating human suffering and economic devastation.
But if a major player like the United States isn't fully on board, it feels like a significant missing piece. How effective can that global coordination really be? Is it like a house built with a crucial pillar missing?
That's precisely the challenge. The U.S., while rejecting the amendments and not signing the treaty, does state it will still cooperate with other nations.
But on their own terms.
Exactly. Without jeopardizing our civil liberties, without undermining our Constitution, and without ceding away America's treasured sovereignty. This implies a willingness to engage, but strictly on its own terms, outside the formal binding frameworks that other nations are pursuing. However, the inherent strength of international instruments and global health governance frameworks often lies in universal participation and commitment.
Everyone rowing in the same direction.
Right. If key nations opt out of specific elements or only partially engage, it can indeed weaken the overall global health architecture. It creates dangerous gaps in a system designed for collective defense. The effectiveness of a truly global response hinges on widespread adherence and trust in shared protocols. And that becomes much harder when a major player signals a different path.
It's a classic collective action problem, as you said, on a global scale. Everyone benefits from collective action, but there's a temptation for individual actors to free-ride or prioritize their own interests, potentially undermining the whole system.
Perfectly put. It is exactly that.
So what specific critical challenges do the sources reveal that will likely hinder effective pandemic control going forward, especially with this fragmented approach?
Well, the sources reveal several critical challenges that really loom large, regardless of the frameworks in place. First among these is just sheer political will. Nina Schwalbe, a prominent public health researcher, argued quite forcefully that the primary obstacle to the pandemic treaty wasn't technical, it was a genuine lack of political will from world leaders.
Lack of will.
Leading to entrenched positions and an unwillingness to compromise on crucial issues. This suggests that even the best designed agreements can falter without sustained, courageous commitment from national leaders. It requires political capital.
And then there's the insidious issue of misinformation, which the WHO chief himself called a torrent of fake news, lies, and conspiracy theories hindering negotiations. That's a huge hurdle when you're trying to build global consensus on life-saving measures.
Precisely. The widespread and rapid spread of misinformation makes it incredibly difficult to build public and political consensus for necessary public health measures, let alone complex international agreements. It erodes trust in science, trust in institutions, trust in global cooperation. It fuels opposition even when the underlying agreements contain explicit safeguards against perceived overreach.
It poisons the well.
It really does. Furthermore, differing national priorities, which are often driven by immediate domestic political concerns, public sentiment, economic interests, they will inevitably continue to impact international agreements and their implementation. The IPR debate, for example, perfectly illustrates this. It pits the economic interests of powerful pharmaceutical companies and the related economic policies of high-income countries against the urgent public health needs and equitable access demands of developing countries.
And those aren't easily reconciled.
Not at all. They represent deeply held beliefs about economic systems, moral obligations, making compromise incredibly difficult.
So, despite all the undeniable devastating lessons from COVID-19, which caused immense human suffering and economic devastation globally, it seems we're still wrestling with this fundamental, deeply embedded tension between national autonomy and global interdependence. It's a complex and ongoing dance.
That really is the crux of it. The path forward for global health response will likely involve a continuous and probably difficult negotiation of these inherent tensions. While the IHR amendments and the broader pandemic agreement represent significant, well-intentioned attempts to formalize and strengthen global cooperation, learning from past failures, their ultimate effectiveness will depend on several critical factors.
Like what?
Like the degree of universal buy-in, genuine political commitment to collective action, not just words, and, most critically, the ability of nations to somehow bridge these philosophical divides between prioritizing national sovereignty and embracing shared responsibility for global public goods, like health security.
Bridging those divides seems like the tallest order.
It is. And the next pandemic, whenever it comes, will inevitably serve as the ultimate, unforgiving test of which approach, cooperative or fragmented, proves more resilient and effective in protecting humanity.
So what does this all mean for you, the listener, navigating this increasingly complex world? We've delved into the deep history of global health regulations, the urgent need for reform starkly highlighted by COVID-19, and the fascinating, often fraught interplay of national sovereignty, intellectual property, and political will in shaping future pandemic responses.
Yeah, we've seen that the current landscape is less a unified front and more, well, a mosaic of different commitments and concerns. The U.S., citing sovereignty and individual liberties, has formally rejected recent IHR amendments. Meanwhile, the broader pandemic agreement has been adopted by many, but certainly not all, with IPRs remaining a particularly contentious sticking point. The big picture is that while there's a clear shared consensus on the absolute need for better preparedness, there's a significant and frankly dangerous divergence on how to achieve it, especially when it touches on cherished national autonomy and powerful economic interests.
Exactly. And this isn't just academic or theoretical, is it? These decisions directly impact how quickly and effectively the world can truly respond when the next novel pathogen emerges, and whether access to life-saving tools will be genuinely global and equitable, or if we'll see a repeat of vaccine nationalism and hoarding. This deep dive truly shows just how many layers there are to something that, on the surface, might seem like a simple policy decision. It's a constant, high-stakes negotiation of priorities played out on a global stage.
It really is. And it raises an important final question, I think. If a pandemic truly respects no borders, can a fragmented global response ever be fully effective in mitigating its impact? Or are we simply setting ourselves up for another catastrophic failure down the line? Something for you to deeply mull over as you consider the future of global health and our collective ability to face whatever comes next.
Thank you for joining us on this deep dive. We hope this exploration has given you a clearer, more nuanced understanding of the vital challenges and immense stakes in global health governance. Until next time, keep digging for those insights.